Hello and good morning, everyone. I would like to thank you very much for the kind invitation to this prestigious conference, and mainly for the very prestigious Forlini Trauma School that passed from a giant of ophthalmology to another giant of ophthalmology, as you could see from the previous videos. I will speak you about the management of glaucoma in ocular trauma, and I think it's worthy to start with a little bit of epidemiology, just to give you an impression of which is the size of this kind of disease. The risk factor for glaucoma after penetrating injury is estimated to be 2.7% in the United States, whereas for after blunt trauma is estimated to be 3.5% in the United States. So if you think that there is an incidence of 2.5 million patients with ocular trauma per year, this means that there is an amount of 75,000 patients at risk of glaucoma after ocular trauma every year. Looking at the classification, we can state that traumatic glaucoma comes from either blunt injury or penetrating injury, and blunt injury itself is divided into early onset glaucoma or late onset glaucoma. Other risk factors are chemical, thermal, radiation, or electric injuries. Looking at blunt trauma, we can see that the early onset glaucoma comes mainly from trabecular meshwork disruption that can be an early or a late disruption. Usually, the early meshwork disruption is due to an increase of pressure due to trauma, but then is usually reversible, whereas the late onset trabecular meshwork disruption needs surgery. Ifema is another common cause of early onset glaucoma after trauma, and this is usually due to the presence of red blood cells, inflammatory cells, and all the fibrinolytic process that goes on during blood trauma. And traumatic iritis is due to a crowding of white blood cells that give a trabecular meshwork obstruction. Finally, coronal hemorrhage can give an ocular hypertension as a secondary closed or angle closed glaucoma due to the mass coming from behind the eye. Going to the late onset glaucoma, we can see as most important factors are blood, so ghost cell glaucoma that has a reservoir of blood from the vitreous cavity, and rarely hemolytic and hemosiderotic glaucoma. Angle recession is a very common cause of ocular hypertension, and lens also problems related to the lens can give a raise of IOP, and this is usually phacolytic glaucoma or a dislocation of the lens or subluxation. Going to penetrating injury, we see that the common causes are quite the same of blunt injuries, so ifema, ghost cell glaucoma, lens dislocation, or phacolytic glaucoma. But then we have other two problems that are mainly due to the open globe nature of the injury. That is a secondary glaucoma, angle closed glaucoma, and the damage or obstruction of the trabecular meshwork. The secondary angle closed glaucoma is due either to the anterior synechia that creates between the iris, the lens, and the cornea after the trauma, or posterior synechia that leads to an iris bombé, so a secondary angle closed glaucoma, or an hydrated lens that makes iris bombé as well. Whereas from trabecular meshwork obstruction, there is lens material, so the presence of fragments of lens obstructing the trabecular meshwork, the inflammation, siderotic glaucoma, which is very rare, or rarely, very rarely, epithelial downgrowth inside the eye, and so damage of the trabecular meshwork and glaucoma. So once we have a clear picture of what is going on, we should proceed with a stepwise technique of management of this kind of diseases. Please take in consideration that surgery is not always the only choice. Up to 75% of cases are resolved with medical treatment. I would like to take in consideration all the drops, so prostaglandin, beta blockers, alpha agonists, or inhibitors of carbohydrate. But for the last one, take in consideration that people with cycle cell trait must be checked, or every patient must be checked for cycle cell trait, because diamox can give an increase of crisis of a cycle crisis disease. So we start with drops on oral management, Diamox or mannitol, just taking in account the systemic condition of the patient, and if it's not working, before taking into consideration other major surgeries, just consider that up to the 50% of patients with hypertension of the eye of an early onset glaucoma can resolve their problem with anterior chamber washout or with the removal of lens. The surgery in this case is still limited if the hyphema is still a total hyphema persistent in time, if there is an ocular hypertension despite maximum oral and topical treatment, or if we are scared about an opacification of the cornea that will then block other possible procedures after few times. So we can perform an anterior chamber washout or an aspiration of the lens. This is an example. This is a young patient who had the primary repair a few days before and then developed, of course, traumatic cataract, but a quite important ocular hypertension. So I decided to operate on him and to remove the lens. I would advise always to use strip and blue in these cases because they give you an idea of if there is still an anterior capsule, and always think that these patients may have a posterior capsular damage. These are very, very soft lenses, as Matteo was underlining before, so you can remove them with an irrigation aspiration maneuver or with a Simcoe cannula, or sometimes if you see that, or you have an impression that the vitreous is present in the anterior chamber, just proceed with the lens removal with an anterior vitrectomy. I always do these procedures in a vitreoretinal list so that I may have the chance of going back if there is a drop of nucleus or if I notice something that is not working in the back of the eye, like vitreous hemorrhage or the suprachoroidal hemorrhages. Here you see we remove the lens with the irrigation aspiration. You will see in a second that for the second part I see vitreous, so I proceed with anterior vitrectomy. And if you reduce the cut rate up to 200, then you reduce the aspiration. Some vitrectors has the aspiration cut or cut aspiration function, and so you can module what you prefer to have first, if the cut of the vitreous or aspiration of the lens. I didn't implant this patient because I just wanted to reduce the pressure, and I then did a secondary implantation with corneal transplantation about 1 year later. You can see another nice advice, as Matteo was showing before, is the use of triamcinolone to see if there is vitreous in the anterior chamber, because you don't want to create traction on the retina, or at least you want to reduce as much as possible traction on the retina, so you can inject triamcinolone and see if there is a residual of vitreous after removal of the triamcinolone. If there is not, you can just close the eye. This is another example, which was a total hyphema after primary repair with raise of intraocular pressure, and this patient at B-scan showed some intraretinal bleeding, but attached the retina. In this case, I also advise always to use the anterior chamber maintainer, even though you have 6 millimeter strokers to go inside the back of the eye. You don't know really the status of the retina, or if you're not completely sure, just approach the eye with the anterior chamber maintainer. In this case, I wanted to remove all the hyphema, and I also did the vitrectomy because I wanted to eliminate any reservoir of blood cell that could then lead to a ghost cell glaucoma, an hemolytic glaucoma, or an hemocytotic glaucoma. You see here that the blood sometimes can be react with the vitreous and become white. This is a typical reaction, and it may be a little bit tricky to be removed. But if you are guided by a nice B-scan echography, you are almost sure that there is not retina over there. And then you will see in a second, once the anterior vitrectomy is over, we go in the back of the eye. The lens was, of course, expelled during the trauma. And there is, of course, a stage 4 vitreous hemorrhage that once you are inside the eye, it's worth it to remove. The ghost cell glaucoma is not very frequent, but if you approach the anterior part of the eye and you know there is blood in the back, I would advise to remove it always. So these are the management of early onset glaucoma. Now let's speak about the late onset glaucoma. The point is this: we have two techniques, trabeculectomy and filtration surgery with shunt. The trabeculectomy is indicated. The only problem is that if you consider the average of patients with ocular trauma, they are either very young patients that have trauma in work context or in an assault, or elderly patient, we have trauma because of a fall. So if you are facing a very young patient, I would not advise to do a trabeculectomy. Not me, but the literature says that patients with a long life expectancy have a high chance of developing a blebitis and so an ophthalmitis during their life, whereas elderly patients may benefit of a trabeculectomy without the use of shunt. If you go to the use of shunt, the most important shunts are Ahmed valve or Berbel tube that works very well. The results in the literature are comparable. They are able to reduce the intraocular pressure of 10 to 15 millimeters of mercury and keep the pressure under control over the years. And whereas the cyclodistractory technique is just reserved for refractory glaucoma. So in conclusion, I would advise to find the cause and to start with a step-by-step therapy. We start with medical therapy and finishes with shot of trabeculectomy, depending from the age of the patient. Late onset glaucoma usually needs a shunt, whereas refractory glaucoma usually needs a cyclodistractive procedure. I thank you again for the kind invitation.